time with one another. But this is also another one of my favorite parts of our patient summit, when we get to listen to our expert colleagues who have traveled in from NIH, like Dr. Kate Lorraine, who have come from the premier Castleman Center in the world, which happens to be just down the street, like Dr. Nasta and Dr. Brandstandler. We set aside, I think it's a whole hour and a half for this panel session. So we have made this a nice long period just so that you can ask all the questions that are on your minds. We may not have the answers to everything. There certainly are questions that we don't know the answer to yet, and that's why we work so hard in the research lab, but we will definitely try our best. You can see the disclaimer that we have up on the screen that ask the questions that are on your mind, but just know that it's difficult for us to give medical advice, and we really can't give medical advice for what you should do in your case. But you can ask questions certainly about your case, and we can tell you, what we know and what we think. But again, just try to make it not too specific to, this is exactly what's happening. What should I do? We can certainly share our thoughts on things. So I somewhat introduced my colleagues, but I'll do a little bit more formal introduction. Dr. Kate Lorraine is a really incredible physician down at the National Institute of Health who focuses her attention on HIV-associated malignancies. She's part of a group down there that has been focused on Castleman's for like 20 or 30 years, like Dr. Yarshman, probably like something like that, right? So this center at the NIH is really amazing, and they did some really pioneering work with Castleman's back in even as early as the 90s. So we are very lucky to have Kate on this panel. She also spent a lot of time working with Tom Aldrich, who is also one of our favorite doctors in the Castleman space. And so I think you trained under Tom at some stage. Tom actually is the physician that wrote my first prescription of sirolimus for me. I remember talking to him and showing the data. So very special place in my heart for Tom and also for the program at NIH. Dr. Sunita Nasta is a phenomenal lymphoma doctor here at the University of Pennsylvania and the Abrams Cancer Center. Has been, I think I remember hearing a number like over 1,000 patients you actively treat with lymphoma. Is that right? Or is it even more than that?
It's more, but I stopped counting a while ago.
It's incredible. Over 1,000 patients that she's actively managing. And every one of them feels like they're the only patient that she's managing, which is a real art to be able to do that. And then finally at the end is Dr. Josh Brandstandler. Josh is an amazing physician scientist. So he both does I shouldn't say both. He does laboratory research into Castleman's. He does clinical research as part of our team and our center. And he also provides patient care here at the University of Pennsylvania. I shared earlier that Sheila Pearson has gone off to medical school at Temple University. She led up our clinical research within our center. And with her leaving, Josh took on that role. So Josh is also now the director of clinical research within our center. So we're lucky to have Josh in that role. So without further ado, we are here to answer all the questions that you could possibly have. What is on your minds? Love it.
So I'm like really loud. I don't need that. Oh.
Well, for the online people, yeah. Let's do it for the online people.
Yeah, I'm right there with you. Big mouth. I got it.
All right, I'll try to be really quiet. So I have a question. I know that the medications that we take are really good for quality of life. I'm just kind of curious about the long term being on these medications, because like I've been on tocilizumab for like 2 years, and every time I go to Boston, I'm like, oh, see you another year, and I'm like, all right, and then I'm like, when am I going to be off this? They're like, some of these people are on it for like 4 more years, and I'm like, okay, so it's like, what does that do to us long term? That's what I'm more curious about.
So you're actually going to tell us, really you are. We're still in the process of learning very much about what the long term is. We do have some follow-up from the original clinical trial work with siltuximab, as well as some work from Japan that showed people can be on it for years. How it impacts your immune system and other organs. We know that it doesn't have direct organ dysfunction associated with it, but you are immunosuppressed. And I think that that is the critical factor in terms of where long-term issues may come from.
Okay. Thank you.
Absolutely. Josh or Kate, anything else you'd add? Maybe Kate, would you want to share maybe a response to if there was a similar question about rituximab, and how you think about sort of long-term rituximab?
So rituximab is a monoclonal antibody, kind of a similar type of medicine like tocilizumab or siltuximab, probably more immunosuppressive than siltuximab or tocilizumab. And we have been following patients for over 20 years on rituximab. They don't continue rituximab forever. There's a set amount of time, but there are certainly changes in the body that happen once you get rituximab, even for a short amount of time. And patients live very long, normal lives. I think in general, when you have any kind of long-term illness that you're managing, it's important that you particularly follow all of the on-time standard guidelines. It's more important for you, and that, sometimes guidelines are written, oh, people could, do a cancer screening every 2 to 3 years or 3 to 5 years, and maybe you're thinking more, we do it more frequently, more on the shorter end of that time period. But that, yeah.
Yeah, I think the best thing we can look toward for predicting would be looking at the patients who receive solid organ transplants who are on long-term immune suppression. Now, certainly that's a much more severe immune suppression that they would be on to tolerate a transplant compared to siltuximab, for example. But I think that would be the right people we can look to if we wanted to look into the future and see what sort of long-term safety issues we can expect from these medications. And I think this is exactly on point that one of the things that would be most important would be close attention to cancer surveillance screening, whether that's mammography, colonoscopies. And then also I think would be important would be cardiovascular health as well.
Yeah, the only other thing I'd add to that is since Kate mentioned the guidelines, so the guidelines for idiopathic multicentric Castleman disease are that you start on IL-6 blockade and you stay on IL-6 blockade. And the term we used when I first learned about it was ad infinitum, which means forever. And that sounded like really, this Latin scary word, oh my gosh. But the reality is that we do know, as Sunita mentioned from Japan, that patients who go off tocilizumab are at high risk of relapse. We've seen it here in the States also with siltuximab, that going off therapy increases your risk of relapse. I don't think it's a 100% chance. There probably are some people who could go off and would not relapse, but it really comes down to also the discussions you can have with your doctor around your sort of risk tolerance. For me, I want as close to a 0% chance of a relapse as possible, which means that I don't ever want to stop my medication. But other people might say, well, actually, you know what? I don't want to have to go get an infusion every X amount of time, or I don't want to do this. And your doctor might say, well, rather than stopping it, why don't we space it out a little bit further? Maybe we'll take it every 6 weeks or every 9 weeks or 12 weeks. We're aware of patients that get every 3 months is when they get their infusion. But again, that's the conversation. I think Kate makes an important point. Starting with guidelines and then having conversations with your doctors who are experienced, and you can sort of find the right thing that works for your risk tolerance. Absolutely.
Sorry, one more thing I wanted to add. Thank you so much for this question, because using the clinical research hat, this is exactly one of the things we want to answer. And so if you are a patient here in this room who has stopped for any reason, whether you did or did not experience a relapse after stopping, please flag yourself to some member of the CDCN staff today, because I think we'd like to see if we can find more generalizable themes that we can elicit from everyone's experiences.
Yes, we need to correlate with where you are in terms of your cytokine profiles also, and see if we can correlate what your clinical patterns are with tapering. So the patients who are on every 3 weeks, if you're discussing stretching, we need to see what happens to your numbers as you stretch. And obviously we don't want anyone to risk a flare, but if you've been very stable and you have that conversation and you're being followed closely, it's reasonable to think about it.
Questions you guys have? Yeah. I'm going to run a mic up here. Thanks, Daniel.
I just want to know, do most of the people that have Castleman, do they have setbacks?
In terms like the disease sort of coming back?
Yeah.
It's a great question. So I'll jump into that first and just say that there are patients where they get diagnosed and they get started on a treatment and they never have a relapse. Those patients typically stay on continued therapy. But then there's also other patients, I'm looking at a few in the room that, you know, were sick, they got better, and then they did have setbacks and it did come back. This is sort of a bit to the earlier question, which is, you know, the best way to limit your risk of setbacks is to maintain staying on drug. But unfortunately, even when you're on drug, there still is a risk that you could have a setback. Anything else you guys would add to that?
And we're in a work in progress. You know, I have patients who had very severe disease. We treated them really, really, really aggressively. And then at a certain point, we decided to back off on therapy and they've been okay, but it's hard because you come in every 3 months and you're talking to your doctor and every symptom seems like something that you're worried about. It's hard. So it's that risk benefit tolerance of the risk of therapy versus the symptoms that you might get in between.
Yeah, you're not alone. You're not alone.
Living in green.
We got 2 in green over there. Yep.
Hi, I'd just like to ask, please, on behalf of myself and somebody else who is IMCD, is there any correlation with having joint pain, I would describe as, and the other patient would describe it as bone pain with IMCD? Thank you.
I think that you're talking about a situation of general inflammation, right? We're talking about cytokine storm as a characteristic of this disease, and that can manifest differently in each individual. For some people, it can be, a drop in platelets or ascites in their belly. Other people, it'll be profound fatigue and joint pain. The trouble with everything that we're trying to do is the heterogeneity of the presentation. But yes, I would say that I've seen a fair amount of joint pain, and it almost seems like a chronic fatigue syndrome type of picture.
Yeah, people are different, and the disease, one disease that we're calling Castleman is really not one disease. It's many different diseases that probably work very differently, because if otherwise, particularly for IMCD, siltuximab should work for everyone if it was the exact same disease. So people are going to feel it differently, and one of the ways certainly would be chronic joint pain.
Doctors are really good at looking at a list of symptoms and telling you that you do or do not fit into that list of symptoms. And we can be very not good at listening to patients, and you are the best person to know, I think, what is associated with your disease and not. Yes, we can all get aches and joint pains, but you know, if you're noticing something that you think really goes along with your other Castleman symptoms or gets better with siltuximab, I mean, I would, as your doctor, I think they should take that into consideration and figure out how to work with you to alleviate that. Absolutely.
And we have some questions from online.
Oh, cool.
How long can infusions be extended for siltuximab?
I think the longest that I've heard is about 3 months. I don't know, Sunita, if you've heard longer than that. Or done longer.
I have not gotten to 3 months. I've gotten to 8 weeks with one patient.
Yeah, I mean, I think about one patient who completely went off therapy, and for about 2 years, he had no problems at all. And I was like terrified for both of those 2 years that he was going to relapse. And then he did relapse after 2 years. You know, hard to know if maybe he'd gotten a dose like every year. Maybe if he'd gotten like one dose in the middle or a couple doses, maybe that would have prevented the relapse from happening. But yeah, there's just really limited data on how far you can go.
And one more from our pre-submitted questions. Does Castleman's make you more susceptible to other diseases?
Yes, that's the short answer. We know that unicentric Castleman's disease can be associated with other hematologic malignancies such as lymphoma and multiple myeloma. And we know that having immune dysregulation, which is a hallmark of this disease, puts you at risk for secondary malignancies. And a chronic inflammatory state can increase, as Dr. Brandstetter said, risk for heart disease and pulmonary processes. So what's really important is keeping a log of your symptoms, having a conversation with your physician, and staying on top of your routine health maintenance.
For the POEM syndrome I'm going to butcher the name of this, but it's daratumumab.
Daratumumab, yep.
Yeah, is that the go-to for POEM syndrome, like a good starting point, or what is the procedure for that?
So it depends upon the manifestations of the disease at the time of diagnosis versus at the time of relapse. So yes, daratumumab has become a mainstay because it can be given with limited toxicity. And we know that the plasma cells that are involved with POEM syndrome and the associated Castleman's disease can have CD38, which is the target for daratumumab. So yes, daratumumab has become a larger part. It's been a fairly recent phenomenon. We've had it for now about, say, 5 years. And it is used in combination with the other myeloma drugs such as lenalidomide, pomalidomide, and of course dexamethasone.
Yeah, the only thing I'd add to that is that I'm aware of maybe a handful of POEMs associated MCD patients who are on daratumumab and have anecdotally heard positive things when they've gone on daratumumab. But as Sunita said, it's still early days because it's only been approved for about 5 years and only really been tried in POEMs associated MCD even more recently than that. So it's still early days, but anecdotally, I can say there's been some positive outcomes thus far.
Is sultuximab considered a successful treatment if you still have to take prednisone with it?
It depends if this prednisone is for symptom management around the sultuximab, but in general, yes, it is part of the treatment.
And I think that the question around like what is success, what is remission, what is relapse, what is cure, I think that like terms are, unfortunately, we all want like to be able to easily say like, yes, this worked, no, it didn't. Yes, you're in remission, no, you're not in flare. But these terms are very much sort of, as we described earlier, like personal to you. And so it's important for you to spend time with your doctor if you're not sure if it's working or if you think it's working, and have them sort of evaluate your whole clinical state, not just one lab test or one symptom, but generally, how are you doing? Can you start to take back the dose of the steroids? And if so, does the whole thing relapse, or do you just feel more tired? And if it's just that you feel more tired when you're off steroids, then your disease is probably being controlled by the sultuximab. But I think that it's important just to remember that there's sort of always hard to give like a definitive yes or no, like yes, it's working, or no, it's not working. I don't know if anyone else has anything like that.
And your goals may vary, as David said.
Yeah.
I have a patient whose major goal is to get to 3 of her son's baseball games a week. Like that's her goal. She's well enough to do that. She considers that a success. Other people want to be able to get off the couch, like what is the goal? And then I'm trying to improve on that goal each time in a conversation with your physician.
Like that. Got some questions up here. Oh, Tracy, you're ready for some more? Go for it.
Yeah, what certain blood tests do you need to make sure your doctors are doing to make sure they're monitoring your disease?
The handful that I'll throw out and then love to hear from colleagues. So hemoglobin, albumin, CRP, platelets, and creatinine. If you're measuring those 5 things and they're all normal, or one of them's abnormal, that's a good sign. I tend to not want to just do one of them because any one of them may may become abnormal for some unclear reason, but not necessarily the disease. But those would be my 5. I don't know if, I know there's some others like VEGF that you like to run as well, but I don't know if you else you'd add.
I think it depends on where you're being monitored. So if you're being monitored at a tertiary care center like here or Emory or the NIH, you may get a panel of cytokines to follow, but that can get confusing as well. So remember that IL-6, you can measure that initially as a measure of the activity of the disease, but siltuximab binds IL-6, so it can actually make the number go up on your testing when you're on therapy. And that doesn't mean that the siltuximab is not working. It just means that you can actually detect it because it's bound. So it can get tricky in terms of evaluation. So sometimes if a patient's coming in and they're not on therapy, I'll measure their IL-6, but if they're on therapy, I won't.
Yeah, that is an extremely, I just wanted to say how important a point that is, because we've seen so many cases of providers being confused and seeing patients do very well clinically with siltuximab, but feeling like the drug has somehow failed them because they see the number go up.
Yeah, so if you're on siltuximab, don't have your IL-6 measured, and if you do and your doctor tells you that it's too high, tell them it's not too high, and tell them to talk to us, and that forget about the IL-6 levels. That's right, for sure.
We have a question here.
In regards to HHV-associated Castleman's disease, many patients also have HIV, and so you should also be monitoring your HIV viral load and your CD4 T cell count.
And what about measuring like plasma HHV with PCR? Do you do that too or not?
Again, there's a lot of confusion around monitoring that because there's different ways to monitor it, and it can be very detrimental if you have many patients who have HHV-associated Castleman's also have a type of cancer called Kaposi sarcoma. And if you have Kaposi sarcoma, your HHV8 level in the blood may be high, and that doesn't have anything to do with your Castleman's. And so that can give sort of a false signal. The way we measure it and major centers measure HHV in the blood is more helpful for following Castleman's disease. So we do follow it. And there's definitely some new, very good evidence that actually monitoring it in a certain way can actually help sort of predict and see if there may be a recurrence of Castleman's coming.
Wow. Thank you.
What kind of results should we be seeing if siltuximab is working for us? So my hematology reports haven't really changed since starting, and my doctor's response to me is, that's because you have Castleman's. Those numbers are going to be low. But I'm not seeing any improvement with the treatment.
Remember that the approval for siltuximab was based on clinical improvement. So it's not really based on your numbers as much as it's based on how it's helping you feel. So if you're having a clinical improvement, meaning your energy's improved, your transfusion needs are better, if your ascites is improving, then the siltuximab is working. So it's a combination of the numbers, but more importantly, how you're feeling.
And if you're still feeling the same way you felt before, then I think you should, have a follow-up conversation with the doctor. But yes, I totally agree with Sunita that that you don't want to just only chase after numbers, like sort of always be worried if your numbers are abnormal. If you're feeling better, that's the most important thing.
And there are people with Castleman's who are very symptomatic with normal numbers.
Mm-hmm.
So, that's the difficulty, is the heterogeneity.
I will also say that sometimes when you get a diagnosis of a rare disease or something that is you're on a medication for, doctors can oftentimes stop thinking about other things that could be going on. So particularly like for women, you may have a low hemoglobin potentially because you have iron deficiency. And maybe that's, if you're doing better on siltuximab, maybe it's time to start thinking about, are there other sort of like more common things that could be contributing to this that I need to think about? It's likely the Castleman's disease, and I'm not disagreeing with anything that's been said, but I do think every now and then, doctors can sort of focus on one thing that's sort of unusual and forget about more common things that could also be going on.
here from Gary.
I was joking with some friends a couple weeks ago that everything wrong with me in the past 7 years has been Castleman disease, and none of it has anything to do with the fact that I've been lucky enough to live 7 years and I'm getting older.
You're not getting older.
But I do wonder, since COVID, if we know anything new about the specific effects of cytokine storms, in particular on cognitive abilities.
Well, I think you're a testament to it. It having a sepsis-like syndrome has known cognitive deficits associated. And we are not very good at recognizing nor at improving those. We don't have easy ways to do that, simply because there isn't like one cause for that. In the short term, we think, okay, maybe it's because they're fatigued, maybe it's because they're anemic, maybe it's because of X, maybe it's because of Y. But when all of those have resolved, there's still a deficit left. And that's the effect of having that profound low blood pressure, having that profound period of time where you were intubated, being on all of the medications that were supporting you at that time. And the issue is that we don't have long-term studies specifically for patients because the number is small, fortunately. But some of the studies in sepsis, for example, do show that patients have cognitive decline after that.
And chemotherapy exposure can also contribute to impaired cognition. Chemo brain is real, and chemo brain can keep going even long after you've gotten chemo.
The way my patients describe it is something like an adult ADD, in that they have all this stimulus and they're just not able to filter out what they need to be able to do the list making and the short-term memory, and they need the tools to help them with that. She's been asking for a long time. No, right here.
This is kind of me specific, but it's a general question. So I have other autoimmune disorders and I've already been on rituximab and I had a really bad reaction to it. And so it's on my allergy list. And I was wondering, are the other medications in the MAB family, are they related? So does that cut off a bunch of opportunities for people with medical allergies?
No. So the structure of some of these monoclonal antibodies are similar, but there are ways that the structure can be altered to decrease reactions, and also ways to modify the administration to like fractionate the dose, give additional pre-medications that can make it tolerable to get these. But the structure of siltuximab is not that close to rituximab such that you would have a reaction.
And for rituximab, there are more modern day versions of those that have the same target, the CD20 on the surface of B cells, that are formulated differently, that they don't have, that people can react to rituximab but not react to these newer generation versions of this. It's essentially the same medication. Yeah.
I've also done desensitization for rituximab as well, so it can be done.
Couple quick comments. One is that I know Penny has described that receiving that new generation of rituximab has been really helpful for her, maybe so even better than her previous experience with rituximab. And the second comment is that Sheila Pearson is in the building. I see her in the back, so round of applause for Sheila. She must be stepping away from her med school classes, but I got really excited when I saw Sheila back there. So so if you ask any questions about Accelerate, I'm going to send it over to Sheila, so just be forewarned.
Yeah. We've had a few questions about chronic fatigue and any treatments that may be helpful. And specifically, one patient wants to know if any of you have tried Adderall for treating chronic fatigue.
Usually I work with either the primary care physician or the rheumatologist, but I have not specifically prescribed it myself. It has been helpful in a few of my patients.
I have used similar medications to Adderall and things like that before, sort of in short periods of time. Often in patients where I felt their fatigue, we could do something about it and we could get through, we could, you know, maybe there was depression that was contributing to it and we were waiting for maybe an antidepressant, which takes a longer time to kick in, or we were trying different things to try to see what would work. We've used it a short period of time. I think for chronic fatigue, it's one of those things that we have to keep working together as patient and physician to try to figure out what works. I think exercise and meaningful social interactions are two things that work really well for chronic fatigue. It is very difficult to sort of, when you're tired, to get up and exercise, and it's very easy for a physician to recommend it. You know, we have to sort of figure out things we can do to get that started, and that's sometimes where medications can fill that gap before we try to get you enough energy so you think you can maybe try something. But I do think also having a good support system, people you can talk to who understand and who are listening to you when you're feeling so chronically fatigued in a way that people are not listening to you maybe. But that support system can be very important for getting you through that time before you feel better.
I will say that having a support network of physicians working with you is important as well, because sleep disturbance can be a major portion of the chronic fatigue, and having a good evaluation of sleep, which is another problem that's very difficult to treat, can be helpful as well.
Yeah, I just add one additional comment related to Sunita's, and that's that those of us with Castleman disease, we should be tracking our symptoms, seeing how we feel. And one of the ways to make sure that you're figuring out, are you tired from your Castleman's, or are you tired because you're not sleeping, is to make sure that you sleep and you take care of yourself. So, you know, make sure you're sleeping, make sure you're eating well, make sure that you're exercising, do things so that way, if you do start feeling more fatigued than usual, you can at least say, well, it's not because I only slept 2 hours last night. It's because, you know, maybe this is related to my Castleman disease. That can sort of help you to tease those couple of things out. And then I also say that, at least in my own personal case, I struggled a lot with fatigue and brain fog for the first 3.5 years of my illness. And then it was actually finding sort of the quote unquote right drug for me, which in my case happened to be sirolimus. But once I got on the sirolimus, I felt like the clouds just sort of went away, and then my energy came back. And so part of it is some patients, there may not be a drug that's going to sort of like control it all, and you will be dealing with your fatigue ongoing. But in other cases, it might be that there's a drug for your Castleman's that will help with your fatigue.
Have you heard of any eye disorders associated with Castleman disease, such as eye inflammation or eye pain or eye dryness?
I would never be surprised.
I agree.
It's a chronic inflammatory condition, and how people manifest in terms of that chronic inflammation is highly variable. Just like we discussed about bone pain or joint pain, you can have blepharitis or iritis or other eye complaints associated.
And you guys have seen some Sjogren's patients too, right?
We have. In fact, that's part of the issue of being a place that sees a lot of Castleman's, is we have people coming in for assessment, and we walk in the room and say, good news, you don't have Castleman's, bad news, you have something else. And, you know, it can be hard to hear, well, I came in with this diagnosis, why don't I have this diagnosis? And it's because if you have this other thing, it rules out Castleman's.
Yeah, it's tricky to disentangle Castleman and autoimmune phenomena. So making sure you've had if your primary symptom is I'm having dry eyes, I think having an assessment for Sjogren's, which are simple blood tests, would be important.
I do think it's important to make sure that you're not just saying everything is due to Castleman's and not getting a proper diagnostic workup for other things, though. Again, I think, making sure that everyone's not just saying, oh, it's Castleman's, and find Dr. Castleman's doc about how to fix it. Make sure that you've actually gotten a good eye exam from an ophthalmologist and they've actually really looked at your eyes and evaluated them and not just said, it's Castleman's, because it might be, but it might not. And, it's important to make sure that we call this a diagnosis of exclusion. I would think that those types of symptoms, we should exclude everything else that would be easier to treat and help you sooner than just saying it could be Castleman's.
There's a question in the back.
Hi. Speaking of other disease, is there any correlation between other immune disease and the presence of other immune disease and relapses of Castleman disease?
Just to clarify, do you mean autoimmune disease or immune deficiency?
Autoimmune.
Yeah, I think that the challenge that we face with Castleman's is, well, first off, I'll say that historically, if you look in the medical literature, there absolutely are papers that will tell you that patients with Castleman disease also have a lot of other autoimmune diseases. And yes, some of those autoimmune diseases, patients with them may have worse symptoms and maybe even relapses than patients that don't have autoimmune diseases. Our current thinking around Castleman's is that the term that Kate used earlier around this diagnosis exclusion, the current thinking is that if you have something that looks like it could be lupus or it could be Castleman's, we tend to say, let's call it lupus and let's focus on treating it as though it's lupus. Now, that isn't like an end-all be-all rule. You could certainly have two bad things happen to the same person, right? But we tend to say if you have something that looks like it could be a more common autoimmune disease and you might have Castleman's, let's really focus on the more common autoimmune disease. And if things don't go away, then let's maybe revisit this idea that there might be Castleman's. And so I tell you that whole story to say that, like, historically, we didn't think about it that way. So a lot of previous papers are like, oh yeah, you have Castleman's and this, you have Castleman's and lymphoma, you have Castleman's and autoimmune disease. But now we think about it more like, if you have something else that could explain how you feel horribly, then maybe that's just what you have, and you don't also have Castleman disease. Is that an okay way to describe it?
Yeah, I think the thing that we continue to struggle with in the field is the diagnosis, right?
Yeah.
There is a set definition that includes particular findings that they see under the microscope, but none of those findings that cause you to say this is lymph node is a Castleman lymph node are specific in that you can see those same findings in other diseases. And this is one of the things that we're most missing, is this very specific test that could only happen in Castleman. And so that's why we need to always be careful with the new diagnosis of a rare condition to make sure that we don't think it actually could be a Castleman lymph node being just kind of a reaction to another more common autoimmune condition or malignant condition.
And the reason we look so hard for that other condition is there are known treatments, there are known algorithms for management that could get you feeling better. So it's not a bad thing to get another diagnosis if it means that you have a treatment plan for it.
Can you tell me, do all IMCD patients get bone marrow biopsies, or is it certain symptoms that have your doctor do that?
I don't think all IMCD patients necessarily need bone marrow biopsies, depending on how they're presenting. If there is a suspicion for POEMs, I think that would be one reason to to do a bone marrow biopsy, because that's where the disease-causing plasma cells might be hiding and living. But otherwise, I don't think of a bone marrow biopsy as an essential part of the staging for Castleman disease.
You always, as Kate was saying, want to rule out other things. So if, for example, you have pancytopenia and we don't have an easy explanation for it, then yes, a bone marrow biopsy is helpful because it can tell us what's going on where at the source. Why did Willie Sutton rob banks? That's where the money was.
Yeah. And one thing that you could do beforehand, before going all the way to bone marrow biopsy, is something called SPEP, or serum protein electrophoresis, and that'll give you a sense for, is there likely something in the bone marrow, like Josh mentioned, to look for. And so I do think everyone with MCD should have an SPEP done at some point. And if you have the SPEP done and it's negative, you probably don't need to worry about the bone marrow biopsy. But if you have SPEP done and it comes back with what's called a monoclonal M protein or an M spike, that's when you should definitely do a bone marrow biopsy. But I agree, I don't think you need to jump right to bone marrow, but you should make sure you get a serum protein electrophoresis if you have multicentric Castleman disease. And I'm just looking at the clock and seeing that we're right at halftime. And so we're going to take a 1 minute off the beaten path. I haven't warned any of my colleagues what we're going to do at halftime of this. But Josh, if you want to lead us off with a
song?
favorite, it could be a song, or it could be your favorite television show that your children are watching these days. If you want to give us that, or song, either one.
It's their favorite or my favorite?
Your favorite that they watch.
Okay, I love Bluey.
Okay,
I'm a big
I like
fan
Bluey
of Bluey.
too. Bluey's good. Bluey's good. Yes, I like Bluey.
I would even watch it without them.
There's some things you just don't want to know.
Yeah. All right, Sunita. So you're up then with your favorite song, like at this moment, or historically. You could just be like, that's my favorite song historically, or it could be what you listened to recently that you really are happy about.
My favorite song.
Or you could go movie too. Either one. I'm gonna give you song or movie.
Well, so I was going to have difficulty with that question because I have 20, 18, and 14. So, but we did go to Barbie, and it was actually really good.
Okay, there we go.
Yeah, I think more men should go watch it. But yeah, the music in that was actually excellent. So I can't pick a favorite, but that's what I've been listening to lately.
Okay. Kate, same question for you. Either a song, a movie, or a children's TV show that you're enjoying watching these days.
Okay. So I actually also saw the Barbie movie, and I was really excited because this song that I used to sing at summer camp, the one that Barbie sings in the movie called Closer to Fine, was one that we used to like belt out at the top of our lungs in like 1992. And so I was really excited that it was in this movie, and then my goddaughter was singing this song, and I was like, that's an old song, right? And she was like, no, it's not. It was in the Barbie movie. That's new. And I was like, but yes, so I think that's my song right now.
And how do you feel about singing it to our audience right now? I'm just teasing.
They don't need to hear that.
All right, so then to wrap out this halftime before we go back to more questions.
David, I think you're skirting the issue.
All right. Anyone who knows me, Sheila, favorite movie? Borat. Borat, yes. Okay. Borat, #1 favorite movie. It's also my second favorite, my third favorite, my fourth, fifth. It's at least top 5 of all of them. It's the best. Borat for sure. In terms of my daughter, Amelia turns 5 years old next week. So August 19th. My favorite show that she's watching these days, I do like Bluey a lot, but I want to give a different answer than Bluey. I saw Blue's Clues for the first time with her, and it was very educational. I hadn't watched it until last weekend with her, so I'm going to go with Blue's Clues. I was happy about that. And I think we can get back to our regularly scheduled programming, back to questions, unless anyone else has any other random questions for us. I just thought we have an hour-and-a-half long panel. Let's break it up a little bit. So we're back to questions. Tracy, go for it.
Yeah, a few more from our remote attendees. Any advice for patients on how to explain to their other care providers what Castleman is, because often they've never heard of it?
Well, I think the team here has set up an amazing website that has a lot of information that is geared toward both the patient and the professional. So I think I would start with cdcn.org. But I think the simplest way to explain it is a generalized inflammatory condition that manifests with lymphadenopathy and a variety of symptoms that can affect many systems of the body.
I like that. And so I like that description a lot. And the other thing is we often in medicine like to put diseases into categories. So like to say it's an autoimmune disease or it's a cancer or it's an infectious disease. And Castleman's, we really don't know where to put it, right? It sort of really sits kind of at the intersection of all of these kind of features that look like this or features look like that. I think unicentric Castleman disease we're closing in on is maybe like a pre-malignancy sort of like, monoclonal sort of condition, but certainly not an aggressive malignancy. IMCD certainly falls in this. We don't really know what the heck's going on, but we're working really hard and we're closing in. We've done some research recently and over the last 10 years or so that suggests quite strongly that there is not a pathogen driving HHV8 negative MCD, at least an active infection. And the reason we thought there would be, and we hypothesized there would be, is that we know that there's a large portion of MCD patients where a virus is driving the condition. That's where human herpes virus 8, the replication of that virus is actually causing the immune system to go berserk. So we just assumed, well, maybe there's another virus just like it we haven't discovered yet. I thought we were going to discover HHV9. I was like certain. I was like, we're going to come up with HHV9, the 9th one. And we've looked really hard. We've used 3 completely different tools and methods to look for them. We've used completely different cohorts of patients, and we looked really hard. And we haven't found any evidence of an infection in patients who are HHV8 negative. Now, one thing that we learned from COVID that's quite interesting is that patients can get COVID, recover from their COVID, and then a month later show up in the hospital with something called MIS-C, which looks very much like Castleman disease. And there's no sign of the virus. The virus is gone, and now you've got this like Castleman's-like thing. And so of course, Castleman's could be the same thing, right? Where though we're not finding evidence of the virus when you're diagnosed, it could be that this has occurred maybe a month or some amount of time after the virus was there, but now the virus is gone and now your immune system sort of goes into overdrive on its own. So we can't rule that out, but we can generally say it doesn't appear that there's an active viral infection that's causing it. And then the jury's still out in terms of whether to call Castleman's an autoimmune disease or not. We've got a study that Mike Gonzalez is leading from our team, along with a group at Stanford, where there's evidence that would suggest that there's similarities between Castleman's and autoimmune diseases in terms of what are called autoantibodies, so antibodies against your own self. And but there was no sort of smoking gun where everyone had the exact same thing that would lead us to say this must be causative. So we've sort of got flavors of autoimmunity in IMCD. We've certainly got flavors of it looking kind of like, certainly like HHV8 positive MCD, and then sort of some cancer-like flavors to it. But really, I think we sit right at that intersection. Yes, flavor is probably not the right way to describe a horrible disease, right? But yes, it's definitely right in the middle of all of them. Yeah.
I had to think about my question. So realistically, being doctors, say I go to a local doctor, could I expect that they could go deep into this Castleman's for treatment? I mean, because they're treating many different people and it's not specific. So should we go straight to a specialist and then find a provider? Or, I mean, that's what we're going to do, but can doctors really handle taking on a patient specialty treatment?
So with any rare diagnosis, it always has to be a partnership. We obviously cannot see you regularly enough if you're far away from us. So we will have to partner with somebody who is closer to you. So I think the key question to answer is not can the local physician take care of you, but is your local physician open to collaboration?
It's an important question because not all physicians are. I mean, I had a physician in my journey who was offended when I said I was going to go to Little Rock, Arkansas to see Dr. Van Ree. And I was okay with him being offended because, you know, I would rather him be offended and me be alive than the other way around. And so I think one part of it is like, yeah, you want to have someone that's open to that. Another part is maybe you don't want to have that person be your doctor if they're not open to collaboration. And you just need to find someone else because there are a lot of doctors. We can help you find a lot of them. These are the best up here, but there are a lot of them. So we can help you find one if your doctor doesn't want to collaborate. And the other thing I'd say is that we spent a lot of time coming up with treatment guidelines to make it as clear as possible for a doctor to know what is the evidence for how to treat this disease. And so, you know, this panel was part of these efforts, and we had, I think, a total of over 30 physicians from around the world to come up with how do you treat IMCD. And the consensus based on the evidence is siltuximab first. If that doesn't work and you're really severe, chemotherapy. If that doesn't work but you're not that severe, rituximab. If that doesn't work, sirolimus, thalidomide, anakinra, and others. But there's clear guidelines that, yes, I think local providers can definitely follow, but because it's rare, I think you want to go to an expert, so that way you're getting the best for you.
And it's not only your local physician. I mean, I send patients to Fritz. Fritz
Yeah,
sends patients
exactly.
to me.
Yep.
I talk all the time with other members of CDCN on patients we have together. I mean, it's a group effort. We're talking about a rare disease and it has rare manifestations and it's different for each and every one of you. So there's no one doctor who can be the be all end all. We have to collaborate.
I do think it's very important, though, that you do have a doctor that you know and trust, though, locally, because if you get sick, you do need to have somebody you can go to who can, you know, help take care of you while you're too sick to see that specialist, or
Yes.
who can answer questions or communicate with your specialist. And so I always want my patients to have somebody who lives near them that I can communicate with. So I think I really think it's important to have a really good doctor that you trust who lives near you. And, you know, doctors cannot know everything. We do not know everything, but good doctors know how to figure out what they don't know and are humble enough to seek out that information. So I think that's what makes a really good doctor, is being able to figure out what you don't know and how to figure out how to get that information to help your patients. And that may be calling an expert, but there's also lots to read. You know, you shouldn't be in charge of educating your doctor. You know, your doctor's trained to learn how to figure out information and get this information. So a good doctor should be able to work with an expert, as you know, as everyone's been saying.
Yeah.
It's also very important to hospital,
Mhm.
because in our experience, one hospital had a large team of doctors, and after 3 months, I suggested, why don't you contact Cleveland Clinic and collaborate? No, we don't do that. Oh, you don't do that? So I took him out of that hospital, took him to U of R, and had the one doctor who knew exactly what this was, and it saved his life.
Yep.
So the institution, or the hospital is very important.
Yeah, every week we talk to physicians around the world to provide specialty guidance on Castleman disease. So we are certainly, this is a calling and it's something we want to do. We want to help wherever the patient is, provide that guidance that the local physician needs.
Yeah, you should feel very comfortable advocating for yourself and your family member.
She's the best advocate.
Yeah, I mean, you know, that it's people who get the best care are people who have family members, are able to advocate for themselves. Yeah. Yeah, you know, that it's really important, and you know, you shouldn't feel shy about saying, have you thought about this, or please explain this again, what's going on, because I don't understand and it's not making sense to me, and one doctor told me something else and you're telling me something, can you please talk to each other? So, you know, communication's often very hard in hospitals.
The one
Yeah.
hospital said, it's rare, whatever it is, okay, but it's progressing. What are you gonna do about it? So then going from Rochester General to U of R, which is like night and day, the experts are strong, and I don't know why I didn't take him in the first place, my mistake. But I pulled it, literally AMA'd him right out of it. I'm not, still in his house. Took him to Strong, and boom, within a day, Dr. Elzubi, that CAT scan.
Wow.
Verified by the PET scan. Moved everything along like that.
Wow.
So we got lucky, perhaps. It was one doctor who knew
Yeah.
what it was and identified it. So
Yeah, I think it just highlights the important role that advocacy plays, and that the loved ones in here, you guys are, I would say as important, but truly even more important when your loved one who has Castleman disease is really sick. Like you're the one who has the voice, and it's tough. And I know, like in my family, my dad and one of my sisters really wanted to know like what was happening and be really proactive. But my other sister like really just like didn't want to know all the details, didn't want to sort of know how sick I was, had a hard time with that. And I think that that's understandable. You know, all of the loved ones in the room, you guys are going to handle the diagnosis differently. But I do think that being able to lean into talking to the nurses, talking to the doctors, what's happening here, I think is really important.
This lady in the front here has been waiting for a really
Karen.
long time.
Thanks, Daniel.
I just have a quick question. When I was diagnosed last September with Castleman's, my doctor prescribed a regimen of Voltrex every day and Bactrim 3 times a week. Is that common for Castleman's patients? I mean, it was attacking my lungs, so I was thinking, I don't know.
I think that my suspicion is that it would be sort of prophylaxis to prevent you from developing some sort of an infection is what they were doing there. I know that Dr. Van Ree, who obviously, he might be virtual, but he's certainly not here in person. Dr. Van Ree is very aggressive with how he treats Castleman's. He likes to use really aggressive therapies, but he's also very aggressive with prevention. So he likes to start you on lots of antifungals and antibiotics and antivirals, sort of because he's giving you these like immunoablating agents. And so it could be that your physician was thinking the same way. I don't know what drugs you were on to treat your disease, but it may be because of those drugs, your doctor is trying to be aggressive with preventing something else. Is that what you guys would think as well?
Yeah.
Oh,
Right,
yes, they
yeah.
probably didn't have to do that because siltuximab really doesn't increase your risk of infection that much, but that's probably.
So, I mean, we obviously can't give specific advice,
Exactly.
but when patients have a lower lymphocyte count, it puts them at higher risk for certain types of infections. And Valtrex and Bactrim are used in that setting. So, like rituximab, for example, really can drop B cell counts. And so my patients who are on prolonged Ritux, I do have them on Valtrex and Bactrim. So it's possible that your lymphocyte count was lower, and that was a reason that they wanted you to be on those medications to prevent infections. As we discussed at the beginning, a lot of what we're concerned about with prolonged immunosuppression is, are they going to get an infection? And so it's preventative.
I actually have 2 questions. My first question is, since you're hearing more patients with multicenter Castleman's with POEMs, is the team looking into other treatment plans besides daratumumab?
It's a great question. Daratumumab, as we described earlier, is fairly new to the game, but we're seeing some positive results. POEMs is the rarest subtype of multicenter Castleman disease, which means that we have the fewest number of samples. And it also means that each patient with POEMs that can give us a blood sample and a lymph node sample, that's huge for us because that's really increasing our ability to detect differences. We do include POEMs patients in our research, but again, we're just limited by the number of patients, whereas we might be able to have 20 or 30 IMCD patients in any given study. Getting even a handful of POEMs patients in that study is quite difficult. But yeah, I don't know if there's other comments.
So clinical trial work can be difficult in that you need a framework of evaluation. So the patients that you enroll have to fit within a framework. And the issue with POEMs sometimes is that the other organs that are affected by POEMs can limit our ability to put you on a trial because the drug that we're testing can affect those same systems. So it's not a matter of not wanting to put a POEMs patient on a trial. It's just, since it's a new drug in a new setting, we want to make sure that we're not going to hurt you. And if you have certain organs affected, it can limit our ability to do that. Yes, eventually, as we get more information and numbers of patients, we can try to focus our trials in specific subtypes, but we're still learning so much about each one of you that dividing up makes it more difficult.
And then the other question was like if the Castleman's at a stable point, but the poem symptoms are showing more prominence, then you stick with the same plan, or is there another plan in place for something like that?
So I think with daratumumab, you are targeting the poems, actually. The Castleman's is a bystander.
Okay. Gotcha. Thank you.
We have a few more questions online about research. One patient has asked if there's been any research done in stem cell treatments.
So I'm not sure. There's a couple different types of stem cell treatments. There's three types. The first one is an autologous stem cell transplant, where you are given back your own stem cells. So you get chemotherapy, and then you get your stem cells pulled out. They're put separately from you, and then at a later stage, you can get a really intensive chemo, and then we'll give you your stem cells back. That's autologous. There's allogeneic stem cell transplant, where you get stem cells from someone else. Because it's a way to basically reset your immune system. You get someone else's immune system in place of your own. And then the third type is sort of more, I would say, like fringe-ish, and that is because it's not allowed in the United States. Not that it doesn't work, but just in the United States, there's a lot of rules on injections of stem cells. But outside of the United States, there certainly are places where they'll inject stem cells into any part of your body to treat your ailments. And there are very positive anecdotal reports. Whether they really work or not, I don't know, because they're very restricted in the US. So I don't know if the question was around like stem cell injections or autologous or allogeneic, but there's actually, within Castleman's, there's very, very little information about any of those three. I don't know if you guys have anything else that you'd add.
So I think the one setting where it has been used is poems. So when poems is diagnosed in the early settings with stable organ function, stem cell transplant has been used. I think Fritz uses it in the early stages, similar to how you treat multiple myeloma, and that can produce periods of progression-free survival.
And that particular one's the autologous stem cell transplant. So it's actually your own stem cells that you're giving back to yourself, would be the type that you would do for poems.
The difficulty with doing other types of stem cell transplants, which I do in the lymphoma world, is we don't know the source of Castleman's, right? Is it a marrow issue? Is it a tissue issue? So like when you're giving stem cells, you're trying to create a new immune system. We don't really know the impact of that new immune system in that setting. So what if we set off a cytokine storm in the setting of doing an allogeneic stem cell transplant that could actually make your Castleman's worse? We just don't know. So having that target, the tissue that you guys are providing to find out what that target is, will help us employ some of these cellular therapies potentially in the future.
Allogeneic stem cell transplant, when you have a donor stem cell to you, is one amongst the most potentially toxic things we do in the blood cancer space in general. So you really need a very compelling, good, clear benefit in order to employ something like that.
Yes, I just had a question. One of the things that we've seen today is talk a lot about the new siltuximab for patients that have IMCD and have been on the previous one, Tuxil or whatever.
Yep.
Do you anticipate continuing to sort of keep them on the Tuxilumab if it's working, or do you anticipate sort of moving at some point, starting to move people over to the siltuximab? Sorry.
I never fix what's not broken.
Thank you.
I have two questions. If you have IMCD, TAFRO, if you have elective or not elective, any surgery, might it set off a flare? Have you found anything with that?
I can tell you that from Accelerate, we've looked for those sorts of things. We've looked for those sorts of co-occurrences where we would say, oh, wow, they had this procedure and they had this flare happen, and we have not seen anything like that appear. Again, that doesn't mean that it couldn't be the case, or it certainly it's certainly something we've thought about and we've worried about. Could any sort of perturbation set off a flare? I mentioned what we hoped from Accelerate was that there would be some really clear triggering factors, maybe even some comorbidities that we know are associated with triggering a Castleman's flare. We have not seen that. What seems to be more, and this is, I'd say, somewhat anecdotal. We certainly haven't done a rigorous statistical test on this, but what seems to be more associated with relapse is around recrudescence, or basically your immune system coming back after being beaten down with chemo. So you get chemotherapy, get your disease in remission, and when that immune system sort of builds itself back up because you're not getting continued chemotherapy is when the relapses tend to occur. And so it's not so much a function of something external that you're exposed to or procedure, but just your immune system basically builds itself back up, you're fully recrudesced and you're back, and that's when the relapses tend to happen in IMCD. That's certainly not the final word. I think we probably will end up discovering other external triggers that are leading to it. But I know Chriswell was in here earlier. Chriswell's done some looking into see when the month of the year that patients get diagnosed with Castleman's, and maybe the month of the year of a relapse, potentially to be like an indicator. Does it happen more during flu season? Does it happen, more at this time of year? And we really didn't see any sort of signal. We saw pretty much similar frequencies month to month in terms of diagnosis, and also even onset of symptoms for Castleman's. But it doesn't mean that there isn't an answer hiding somewhere.
Okay, my other question was, you talked about having a good diet and exercise. Does an autoimmune or an anti-inflammatory diet help you more, or does it just mean eat a good diet? You don't have to follow those certain steps or guidelines.
I think you'd have to define what you mean by an anti-inflammatory diet. I think what I emphasize with my patients is decreasing processed foods, trying to be as whole food as possible.
I don't run. I have 8 surgeries on my left leg because of the accident. So legally I don't run. I walk. I did New York Marathon in 2019 and I walk 8 hours, 26.2 miles. One of the things that I learned is you have to hear your body. People don't realize tomatoes, strawberries, things that might sound stupid, like a tomato. Yeah, it's not good for you sometimes. So you have to hear your body and see what it goes with you and keep moving.
Yeah, I think that there's obviously a lot that's been written and described over the last 10 years or so about really strict diets that can be really helpful for certain conditions. And obviously there are some autoimmune diseases where it appears that there's a really clear correlation where if you eliminate these things, you have improved symptoms. We really haven't seen anything clear like that in Castleman disease, where there's this is a diet where we've heard repeatedly or even a couple times that it seems to have changed something. I mean, the example that I've used when I've talked to some people about this is I wasn't eating any diet when I was sick, right? When I was in the ICU, I wasn't eating anything. I was getting a feeding tube. And so it's hard to say that what you eat is going to stop your Castleman's, but I do think eating well and taking care of yourself, eliminating processed foods, doing the things that you already know are right, I think is the best thing you can do to put yourself in a good position.
I just want to make it clear that there's no diet that you can have that gave you Castleman's or that made your Castleman's come back. It's not your fault if you develop Castleman's. It's not because you didn't exercise or because you ate, something in particular. It's just horrible luck, and it's really important not to blame yourself for developing this type of disease.
And forgiving yourself. If you cheat, it's okay.
Yeah. We all do.
Yeah.
I've got a couple of questions. The first being, is there a connection between Castleman's and pulmonary hypertension?
Yes. Again, we're talking about a rare condition that could present in a lot of different ways. Where I've seen pulmonary hypertension has been in the setting of patients who've had TAFRO or a profound cytokine storm where their lungs have been injured by that storm, and as a result have pulmonary hypertension. I have not yet seen it as a primary presentation. It's more secondary, but I never rule it out in this disease.
Okay, and my second, kind of unrelated, after about how many infusions of Sylvant can you expect to see clinical improvement?
In my experience, it's usually taken about 3 or 4 before patients feel better. This lovely lady in green has had her hand up several times.
Hi, thank you. I have 2 very quick ones, and one you may or may not be able to answer, please. One is, how often do you recommend PET scans?
It depends.
Okay.
Definitely on diagnosis, and then at least initially, as I'm following the disease, 3 to 6 months after the start of the therapy. And then after that, I prefer to do that with symptoms. I worry in a chronic disease like this that I'm going to make you glow in the dark.
Thank you. Can IMCD cause elevated calcium levels?
Yes, it depends upon the clinical situation.
Thank you. And the last one then, can you talk about the recent research about IMCD and GI issues?
Sure. Yeah, I can share about that. So from Accelerate, we just collect all the data on every patient, full medical records, extract somewhere between 3,000 to 4,000 data points per patient from your medical records. And in the process of doing that, we found, and I think it's somewhere over 80% of IMCD patients have some GI disturbance in their record. And now a lot of this is what you would call non-specific. So when people are really sick, they often will have nausea and vomiting and abdominal pain. But that is what we're seeing a lot of nausea, abdominal pain, vomiting, increased LFTs, so liver function tests in Castleman's patients, which again, these are sort of quote unquote non-specific. You've seen a lot of people that are really sick, but I think it is good for us to recognize because sometimes it's thought of as like an anomaly, like, well, that's not usual, nausea and vomiting isn't a typical presentation, but certainly we see a lot of nausea and vomiting in both diagnosis and also relapse settings.
Thank you.
I just want to know, when will other states be like educated more on this? Because I don't talk to people today and they said that where their kids was diagnosed, or the person was diagnosed within a month, which in my situation, my son sat in the hospital and was diagnosed within 5 months.
5 months?
Yeah, and he was in the hospital the whole time. And that's why I'm saying they diagnosed him with different things. And then they finally said TAFRO, but it took so long. And he was like, I kept trying to get him transferred to the Mayo Clinic because I live in Minnesota, but they wouldn't transfer him because they said he was too sick. So we were stuck at Children's, and he went in July 31st, and they diagnosed him in November, the end of November, and he didn't get out to the end of December once the medicine started working. But I was just saying, they were not they didn't barely know anything about this because he came in and he went into a coma August the 2nd, and all his organs was shutting down. So they should have knew something. They didn't know anything until to November. So I'm like, would other hospitals get I know y'all may talk to other doctors, and I know his doctors were sending his stuff here, but that was after they knew what he had. And everybody was telling me, get him transferred. It's cancer. He looked like he has cancer. And I kept telling them, is it cancer? But I'm so young, and I'm not, like she said, I can't I'm not I couldn't speak for myself at the time. I just had a baby. I was just stressed out. So I just left him there. And yeah.
We're so sorry. We're so sorry for what you went through. You did all the right things. You look so healthy, and you're looking so good right now. And you did all the right things. I'm so sorry about what you went through. Yeah.
I just feel like he kind of suffered, but I feel like he's very well now that they knew he had the Castleman and they started treating him. And he did get out the hospital within a month, but it was just like it was hard. He was 15 and he sat in the hospital for 100 and some days. It was just the worst.
We're so sorry for you and what you had to go through. You look so good though. I'm just so happy to see how good you look.
So great.
Yeah, I mean it's amazing, and I know that doesn't take away the pain because of course it's such real pain. I think that a couple things that I would say. One is pediatric Castleman disease happens a lot more commonly than I think that we thought historically. About 20% of patients in our registry are kids. And if you look in a lot of pediatric medical journals and textbooks, there's very little, if anything, about Castleman's in kids. So pediatricians just aren't looking for Castleman's. That's just not on their radar. And one thing that we're trying to do that Josh is helping to lead up is to try to get out information about pediatric Castleman disease through our registry. Let's get papers out. Let's talk to pediatricians. Let's make sure it's at their big meetings. So that way they know to look for it. Because if they don't know to look for it, it's hard to find it. So I think that's one part of it. And then the second part of it is this even includes the adult world. And that's just that the diagnosis is harder than most diseases because there isn't a simple test, because it requires a lymph node coming out and all these subjective things. And so we've got work to do on our end with the CDCN to do a better job of finding a blood test that can help you to lead someone to a Castleman's diagnosis, to find a lymph node test that's much more objective. And so, I mean, I can tell you, hearing your story, and every time we read through every one of your medical records, that's what really drives us to say, like, we need better diagnostic tests, period. And then in addition to that, we need to raise more awareness among pediatric hospitals. So thank you for sharing that. But I can promise you, we want to help so much.
I would just say that, it's the trauma of what you went through doesn't go away just because you're better now. That is a very, very traumatic situation, both for your son and for you. And so people may be like, why are you still upset? Because he's better. But that is just so, it's very traumatizing to be critically ill for so long, be in a hospital away from family, have your loved one be in that situation and feeling powerless. That's something that you should know. Most people are not just getting over that, and they need support, and that it's okay to still feel like that trauma. That's normal.
And that can be with any diagnosis that's that real. I have patients who like walk into the hospital and they get nauseated, just the smell of the place. Okay. And that's years after they were originally diagnosed. I was like, Dr. Noster, I love come seeing you, but walking into this building is a problem.
Yeah.
Okay, I'm next. So I just have a comment and a question. So the one comment is Nick had a biopsy under his arm. The hematologist suggested Castleman's, pathologist ruled it out, right? I think I told you, Josh. And then the neck biopsy confirmed it. So it's not just one biopsy, it's many. So which leads me to the bone marrow biopsy showed fibrosis. And they did a JAX 1 and 2 test negative. Have you seen a correlation between the fibrosis and the bone marrow to Castleman?
Yes.
Okay.
It's one
I
of the
just
known
wanted
findings.
confirmation
We do.
on that. Thank you.
Yeah.
We do.
Penny in blue had a question.
And I would just say one thing that can be done when people are very sick and they're saying, no, we can't transfer a patient, they're too sick. You can actually send the pathology, request the pathology from a lymph node to an expert center like the NIH or Penn for the pathologist actually to review it. Because it's not just the doctors caring for a patient in the hospital who have to make the diagnosis, it's actually the pathologist. And pathologists are not aware of this either. And so you can actually have just the pathology material sent for a second opinion.
And we did that.
Good.
When it's strong, from Rochester to it's strong, they wanted the slides, they wanted the information, they want, and as soon as they got it, it was the ball game. So I'm just trying to share our story that, you know, just because one pathologist said, oh, yeah, no, that's not Castleman, and the other, you know, hospital said, oh, yes, it is. You know,
Yeah, I would just have some caveats to that though, in that you know, we've had a lot of conferences of the physicians on the scientific advisory board and the CDCN group of physicians, and we can get 3 pathologists into the room and there'll be 5 opinions about what their lymph node looks like. So I mean, it can be hard, and you know, you can have an institution that says, okay, this is up and down Castleman's, and you'll send it to Elaine Jaffe at the NIH and she'll be like, nope, that's not it. So like there is unfortunately still this gray area of looking at a sample and there's just not concordance. So I have a little grace for physicians at other institutions who don't see as much, because it can be really, really hard.
I know that Castleman's is connected with acquired immune deficiency, but is there any correlation with primary immune deficiency in Castleman's? Like, has there been any data with that?
There has certainly been for HHV associated Castleman's. We know that there are certain primary deficiencies that
Like hypogammaglobulinemia or common variable immune deficiency, or like low IgG levels and stuff like that.
Not those in particular, as far as I know, for HHV related. I'll let the others talk about IMCD, but I would definitely not be surprised if there are certainly immune deficiencies we haven't pinpointed yet that would be associated with IMCD.
I'm just curious because my youngest has a primary immune deficiency and he gets infusions in his stomach every week with, you know, does Gamma Guard in his stomach, you know, and he's 10. And so it just makes me curious. That's why I wanted to know. So.
I see we've got just about 5 more minutes before we wrap up. I just want to make a comment that these questions are so great. And yeah, I mean, the loved ones in the room, the patients, you guys are all asking all the right questions. You're championing your loved ones and your own care in all the right ways. So thank you so much.
I'm over here.
Penny number 1. That's penny number 2 over there. This is
I'm
penny
the
number 1.
I know there's been some research into the intestinal problems and the gastrointestinal problems, specifically in IMCD. Has anyone made any kind of a collaborative list of other ailments that we might be suffering? For example, diabetes, female reproductive problems. I think there's a lot of us who have had female reproductive problems. Maybe not necessarily having a child, but cysts and endometriosis, things like that. Other things that might come along other than the gastrointestinal. We know that the liver is kind of related too, right?
Yeah.
But what other research is being done on other things?
Yeah, so that study that led us, or sort of uncovered the GI problems were a real issue, it went through every single thing that patients have. And so we have a study that'll get published in the next month or 2, and would be, and by the way, every time I talk about a paper, the only reason that papers are important are because it gets research to doctors. And so, but it also should get research to patients too. So for all these papers, like, we just should get them to you guys. But in this particular paper, we list all of the things, whether it's diabetes or it's, you know, reflux, whatever it may be, everything that got diagnosed in someone with Castleman's before their Castleman's diagnosis, everything diagnosed after their Castleman's diagnosis, all of those things are captured. Because again, when you join the registry, we take every bit of information out of it. So yeah, we can happily share that. And I don't know if, Josh, if you remember any particular things that stood out from that list.
No, I don't remember particularly about the 2 issues you mentioned in terms of diabetes or about. Yeah.
But what would be cool is, like, we can share that in like let's say the Facebook group for the CDCN, and like you guys could add other things or add commentary and say, well, actually, like this thing that's number 50 on the list happened to me too, and maybe share some additional comments. Maybe that's something that we can do after this is, and maybe that's something that we start doing more often as an organization, is that when we publish a paper and there's some finding like that is really patient-centric, we can just put those sorts of lists into our Facebook group. And Penny, you can sort of annotate like, hey, number 13 on the list, I had that and this is what helped me.
Yeah.
We can do it.
Last question, maybe from our online participants. Quite a few questions about knowing when is it time to try a new treatment?
I think it's difficult. Siltuximab as a treatment, if it's not improving your quality of life and you've given it 6 months to a year, and you're otherwise stable, I think it's time to have a discussion. We do have a trial open for patients right now here at Penn. We are looking for patients who would fit that criteria. It's hard, as we discussed, if you're on a treatment that's making you stable and providing a quality of life, I probably wouldn't change in that setting.
Yeah, I think that it's a discussion with your doctor, and all of us have different sort of feelings about what we want. Do we want to go to 3 baseball games a week? Do we want to be able to chase after Castleman disease all day, every day? We all have different goals, right? And so depending on your goals and what your drug is doing for your goals, you need to start having those conversations with your doctor to say, like, these aren't hitting my goals, recognizing that the other drug might not help you achieve your goals either, right? But it might. And so I think it's really about talking to your doctor.
And just a plug for the trial, there is a travel support for it. Tracy works on that all the time.
Yep.
So if you are far away, we can get you onto the trial either here or in Arkansas, and potentially maybe a West Coast site soon. So for those online, if you're looking for that, we are looking for participants.
Yeah, and the only other thing I'd add to that is, yeah, we cover all travel-related costs. So it shouldn't cost you anything more to be a part of the clinical trial than, and actually maybe even less than standard, than you typically would pay for to see a doctor. And yeah, obviously would love for you to join. You need to have received siltuximab, and it have not been sufficient for you in order to be eligible for a trial. Looks like this is the last question.
I have a couple questions. So, sorry, David, and everybody else.
We're in overtime.
Before I got sick, before I got sick in July 2021, I had my COVID vaccine. And so that was like the second one I just had a couple weeks before I started showing symptoms. Can the vaccine itself set off a cytokine storm?
You asked the easiest question last. I'm so glad that you made it. I'm just teasing. No, this is obviously a very difficult question that is just hard to know the answer to, because obviously we're fortunately fairly recent to the COVID vaccine, and certainly have thankfully not seen a bunch of people showing up with Castleman's after they got a COVID vaccine. Maybe not surprisingly, there are a few patients that developed Castleman's after they got the COVID vaccine, but like most people in our country got the COVID vaccine. So like if most people in the country got the COVID vaccine and some people got Castleman's after COVID, it's hard to, or after the vaccine, it's hard to make any sort of connection there. But not to say that there couldn't be, there definitely could be. But the good news is that of the 200 million or so Americans that got the COVID vaccine, most of them didn't get Castleman's. But I don't know how else you guys would think about it. I mean, the answer is we don't know. That's the real answer, is that we don't know. But that's sort of how I think about it as someone who's got kids to get vaccinated, and I make decisions about getting vaccinated. That's kind of how I think about my risk. What do you guys think?
Same. I don't know that you can actually make that link definitively. There's just not enough people who were defined that way.
Yeah, there are described cases of people getting COVID vaccines and having different kinds of inflammatory effects, or having, as what you're telling me in your personal experience with having Castleman, there are also people having COVID infection followed by this. there's no good answer to this that can be data driven. My suspicion is that any sort of inflammatory insult can tip someone who was otherwise prone to it over in toward a inflammatory state at Castleman.
I have another question. My second question.
Is it easier than the first one?
I hope so. So I was born with hypothyroidism. Well, not. I guess. Was I? Well, yeah. So when I was in the hospital, my TSH levels were up, and then it was about a year and a half ago when I started having high blood pressure issues. And I don't know why. I didn't know why at first, but then when I had a adverse reaction to a drug, a blood pressure medication drug, the hospital discovered that my levels were like way off the charts than they should have been. Is there any link? I know I've probably asked this question before. Is there just any link that maybe my thyroid levels can be set off by the disease or siltuximab? Well, obviously not probably because I didn't have siltuximab at my first hospitalization.
Were you on steroids during that hospitalization?
Yeah.
So I think steroids could affect that.
It's weird though because I was on steroids after when I had a high blood pressure issues in February last year.
I just don't know that we can clearly state that one cause we know that patients with, say, an overwhelming infection can have alterations of their thyroid hormone levels and have different needs for replacement than they did when they weren't septic. So my assumption is that that would be the same when you have a Castleman's flare, is that you have alterations of your thyroid function in that brief period that then would stabilize once the flare is managed.
So I might have had a mini flare possibly?
It's hard to know, but yes, it's possible.
Okay, thank you.
Thank you guys all so much for your great questions. This is really wonderful. Oh yeah, hold on 1 second. Well, what do we got next before we do pictures? Perfect. Thank you so much, Malava. Yeah, let's do a picture.